little bit, when in fact it's nothing to do with that. It's nothing to do with not succeeding. It's to do with the trauma that your body's been through, and you've had a change, and that change has caused the tissue not to work as efficiently. So you need some help as to how to make that happen again. I think the other thing about men is men don't really have a clue that they have a pelvic floor. And I see a lot of men with erectile dysfunction, and men think erections are a gift from the gods, and they're bestowed upon them from on high, and they have no connection between how that might work. And that's not true for every man, but generally that is the case. And when something goes wrong with the pelvic floor, they're often bemused, perplexed, anxious, upset, quite focused to get something to help it. And it's all of that is understandable, I think.
Thank you very much once again for being here and for wanting to globalize pelvic health together, for participating in this series of conversations. You say that you are a musculoskeletal physio and that you've been spending most of your life as a clinician, but you're also teaching and doing research. And I'm really grateful for that teaching role of yours, because that was actually how we got to meet. Right. And a big adventure is about to start for you, that is embarking on this PhD on pelvic dysfunction and pain, which I find so relevant, and for sure you even more. And this is now because, again, on your own words, your kids are finally grown up, and you have some time to go back to study. So your life happens in Edinburgh, in Scotland, with your partner and 3 dogs. You enjoy getting outdoors as much as possible. And since you're almost 60, you say that you like to spend time keeping fit and active, which is a very, very clever and wise choice. So let us just know how are you and how do you feel?
Yeah, well, listen, thank you very much for asking me. I feel quite honoured, really, because I know the list of people that you're speaking to, and it's quite an honour to be considered in that list as well. So thank you. I was really delighted to meet you in Liverpool a few months ago, and when you were on the course, and I hope that you find that useful. So I think. Yeah, so I guess I always feel a little bit of an imposter in pelvic health, even although I've been working in it for over 20 odd years. I've been a physio for almost 40, and I've been half of that time I've probably spent in pelvic health. My background is also in dance medicine and sport, but my big kind of passion really is pain, chronic pain, complex conditions, and really working closely with patients to help them on their journey towards getting back to a full life. And I think certainly I started out a long time ago. I did a specialist certification in Canada in manual therapy, and I was very, very focused on hands-on treatment and joint mobilization. And I studied with Diane Lee and some really other excellent Canadian physiotherapists. I learned an awful lot of really good technical, practical things to do in the clinic. And I think what happened was how I got into pelvic health was I had one day a chap came in to see me, and he said, I have some prostatitis, and I'm here to see if you can help me. And I said, I think you probably need to go see a urologist, really, because I'm not sure that I'm your man. And he then told me this a story. He told me his narrative, and it was the first time that I had heard this story, really, a story of someone that had been experiencing pelvic discomfort, and not musculoskeletal pelvic girdle pain, but more pelvic floor pain. And he had been to see multiple urologists. He'd had many prescriptions of antibiotics. He had ever increasingly invasive procedures done with ever diminishing returns. So every time he went for another test, the test was it was equivocal. It didn't really say anything. It didn't give anyone other ideas. And eventually, after seeing maybe, I think it was perhaps his 6th urologist, he had kind of said, look, there's nothing we can do for you. And he was 26 and he was in a lot of pain and he had some sexual dysfunction. And he had come to me because on my website, in the clinic website, it said that I treated a pelvic girdle dysfunction. And he wondered whether or not this might help. And I said, okay, well, let's have a look. I said, I'm not sure, but I said, I can't promise you anything, but let's see how you move. And I'm a big believer in the kind of the whole connection of the body. And certainly from day one up until now, I've never been a very pelvic centric pelvic health physio. So I tend to always look very globally. And so anyway, we started looking at him, and to cut a long story short, after maybe 2 or 3 sessions of looking at his pelvis and getting him moving better, teaching him how to do exercise, teaching him how to relax his pelvic floor, teaching him how to load it up in a better way, you could say, then what happened was he got about 50% better. Now, at the very beginning of because I was used to treating complex pain patients, I had asked him what his expectations were of me and what would he accept as an improvement. And he said, well, to be fair, I would take anything. I would take 10%. So suddenly after 2 or 3 sessions, I was as surprised as him, and he was 50% better. So I think you see these patients as well, Elizabeth, and pelvic floor patients are very motivated to help themselves and are very motivated. And it was round about the time of the advent of the internet and this new kind of idea of patients being independent to go and search for information. And he brought me a book called Headache in the Pelvis. And I read it, and I always tried to think of myself as a scientist, and I always tried to be very skeptical of new ideas. But I read this book, and I thought, well, you know, the biggest epiphany I had was, here was I, a musculoskeletal physiotherapist treating the pelvic girdle for 20 years, and I had never considered the muscles. I had never thought about the pelvic floor as a musculotendinous fascial unit. And I suddenly had this moment where I thought, wow, that's mad, because I wouldn't do that with the shoulder. I wouldn't do that with the knee. I wouldn't do that with the foot. So I was kind of shocked a little bit that I had somehow, and then I reflected upon it, and I kind of realized, well, I thought that basically pelvic floor, pelvic health was taken care of by women's health physios, and I was equally guilty of never considering guys to have pelvic floor issues. It hadn't even entered my mind. And so we looked at the book, and I thought, I'm not sure. It seemed fairly straightforward. At that point, trigger point therapy was very kind of trendy, and it was quite commonly accepted. And we know that, you know, that has been challenged, and the way that we think about muscles that are non-relaxing or muscles that are too sensitive is very different to how we did all those years ago. However, well, to cut a long story short, we decided I learned how to perform internal exams, and I then decided to assess his pelvic floor on the basis that he understood that I was pretty inexperienced at this, and we were going to work together. And he was happy to go along with that, and he consented to that. And I think he was a very brave man. And so we went ahead and treated him, and we got probably another 20 or 30% of improvement. And I was kind of surprised at that. And that was really the start of my kind of experience in pelvic floor physiotherapy. And I actually really believe that it might well have been the first and the last patient I saw with that condition, had it not been for the internet, because this patient basically, it was at the advent of maybe patient support groups. And what happened was my name was placed on this patient support group, and people started calling me, and the phone started ringing. And then it was at that point that I realized how big of a problem it was. because I was getting 4 or 5 phone calls a week, and I have to really admit that I was really overwhelmed to begin with. And I was before I came to speak to you today, I was kind of reflecting on what I used to say to patients and what I say to patients now. And all those years ago, what I used to say to patients was, look, I really don't have much experience. You're my 20th, you're my 30th, you're my 40th patient. So we're going to have to work together with this, and you're going to have to be patient with me. And I think I'm forever grateful to that group of patients for putting their trust in me all those years ago. I feel very privileged to have managed to work with that group of patients that really helped me end up where I am today, really. And so what I think the biggest thing now is 20 odd years later, maybe not quite 20, but close to that, I'm now at the point where, patients come in and I listen to their story, I read their narrative, I hear what they have to say to me. And then I can say to them, look, your story fits the story that I've heard before. And if we can assess you and we can find signs that confirm or reinforce that story, and also signs that I've found in other patients, then the chance of me being able to help you is quite high. And that, for them, I think it's often the first time that they've ever been told that there's anything that can be done. So I'm in a really privileged situation to be working with these patients. So that's where I am. And I started with men, and then I had a couple of women come to see me. And I realized, so I kind of decided at that point that I needed really to develop my skill set a bit more. So I went off and did the specialist women's health physiotherapy courses in the UK. Again, most of the courses I did were kind of prolapse and incontinence, not really much about pain, which was the thing that I was really interested in. And so I learned a lot from these tutors and from the POPG, and I did learn a lot on those courses, but I decided that I couldn't really find a pain course. So that's when I kind of decided to start teaching a little bit. And it's when I started looking into pain a bit more and studying pain a bit more. And I did a NOI course, and then I followed a lot of the NOI literature, and just basically developed my skills in that area. And then realized that one of the good ways to challenge yourself is to actually try and teach that to other people, and to see if you have if what you're doing makes sense. Does it fit in a framework? Can other people follow that? Is there some science behind it? And we might be able to talk a little bit about that later, because the whole thing about science is really important, because we have to have a good scientific grounding for what we do. And if we don't have that, then we have to be really careful about the language we use, and we have to be really careful, I think, about the claims that we make about what we're doing and how the treatments help. And sometimes just be very honest and say, if we don't know why they help, then that's okay. For now, that's okay. But that's one of the reasons, I suppose, I'm interested in doing a PhD, because I think I've become kind of frustrated by the lack of knowledge that is out there to underpin how we work in pelvic health. And I kept waiting for someone else to do it. And there's lots of good researchers out there.
Sure. So I think I got frustrated by the fact that there was science out there. People were evidencing different things, but I've just decided that I'm interested in, what I'm really interested in is the effect of movement and exercise on pelvic floor pain and chronic pelvic pain. And so I just decided that's the thing that I do all day long, and I need to find a path towards evidencing that in some way. So that's my plan.
It's a great plan.
Yeah, it's exciting and it's frightening. And I also have, I'm really lucky. I have some great pals in the physio world, Jilly Bond being one of them, and she deserves a big shout out, because she is really she's really helped and supported me into where I am right now. And actually, her and is going to probably continue to do so through this whole PhD process, and we'll hopefully maybe be on the journey together a little bit. So I'm really excited about that, and so that's where I am. That's my story.
It's an amazing story, and I'm sure there's much more to it, but thank you for summarizing it so well. And when we met because I went to do your course on the Athletic Pelvis, which was amazing. Too short, I would say. I would love to have a course like that for 2 weeks at least, because there's so much to it. I mean, there's so much research that you presented to us, and there's so much of your clinical expertise that you also put into the course. And it's an approach to pelvic health that is out of the mainstream, if we can call it like that. I mean, when we think about pelvic health, we still think about it much more from the urogynecology point of view. And I think that's why I loved it so much, because it kind of fits very well how I very empirically think, as well as a physio. So would you like to elaborate a little bit on how you moved from musculoskeletal physio to a kind of a sports physio as well, and how pelvic health kind of fits in the middle of all of that?
Sure. So I think I learned a lot from my pelvic health patients who weren't sports people. And I started to wonder if some of the skills that I had learned in pelvic health, including internal exam and kind of connecting back into your pelvic floor as a functional unit, could be useful in some of the hip, groin, and leg pain patients that I was seeing. And I began to wonder if some of the more recurrent diagnoses, like recurrent hamstring tear, recurrent adductor tear, osteitis pubis, all of these kind of descriptive diagnoses, I began to wonder if perhaps there maybe was a connection between them and the pelvic floor. And sometimes, I think I think what happened was I had a patient that showed up, and she was a competitive runner. She was a competitive athlete. She was, I think, if I remember rightly, she was like 1,500 meter runner. And her history was that she had the onset of pubic pain that was very typical of what you might expect from a stress fracture, where she found it started to impact her high intensity training. She reduced her training. And nothing happened. It didn't relax. It didn't disappear. It didn't get better. So she modified the load. Still didn't get better. She stopped running, and it didn't get better. So all this time she's seeing orthopedic specialists, and she's given a diagnosis of chronic adductor strain, osteitis pubis. She then had it injected with steroid, and then that made it really bad. And the next thing that happened was she found that her history was that she then stopped being able to walk very far. So you had this thing where she was very, very active, training every day, and suddenly her life and her world and her activity was just like really compressed, shrinking. She was quite depressed. She really was hopeless and miserable when she came to see me. And at that point, she couldn't travel on public transport in Edinburgh because we have a lot of old streets with cobbles. And when the bus wobbled, the pain was so much. When she came to see me, she was a very interesting woman. She was doing a PhD. She was a specialist in sports science, and she was very open to different ideas. And when she came to see me, she got referred via a coach, not by a doctor, but via a coach, because basically it was a career-ending injury. She hadn't run. She could possibly in Commonwealth Games, perhaps Olympic Games level athlete, and she couldn't stand up when she came to see me. So when she came to see me, she was on crutches, and I started asking her questions about the normal musculoskeletal scan questions about load and range of motion and activity, aggravating factors, easing factors, like painkillers, what she was doing and what she'd done to help it. And when you heard her story, it was on the surface a very typical story of someone developing an overload bone injury and having a stress fracture. But all of the investigations were negative. The MRI scan was negative. There was no edema in the bone. There was no there was maybe some signs of bone stress, but there wasn't really a frank fracture, which would have accounted for her inability to weight bear and the pain that she was suffering. The other thing that she then during the conversation said to me, the really annoying thing is I have to go and pee all the time. I have to get up and pee. And my pelvic floor brain went, pardon, what did you say? She said, I have to go pee all the time. And I said, oh, tell me more about that. And she said, well, I go to the toilet. And she gave me a very typical history of urge incontinence. And I thought, and how long have you had that? She said, oh, it started when this started and it's got worse as this got worse. It has become worse. And I said, do you have any other symptoms that you felt for? And she said, yeah, I can't have sexual intercourse because it's really painful. And by this point, I was like sitting up quite tall, thinking very attentively, thinking, okay. So I assessed her and I couldn't really find any musculoskeletal issues at all. Her lumbar spine was fine, the range of motion, she was pain inhibited when strength testing, but other than that, I couldn't really find anything. She did have some tenderness on her symphysis pubis, and she had some tenderness on her adductors, but no pain on resistance, no kind of nothing to suggest there was a contractile element in the global muscles, really. So we had this conversation, and I said to her, I put it to her, I said, look, I have this idea that perhaps this is coming from your pelvic floor. And she said, that wouldn't surprise me because I think it feels deep inside my pelvis. It doesn't feel in the area. So we had a big conversation, and because I felt quite confident by then to assess women's pelvic floor, female pelvic floors, because I'd been on the POPG courses. And I said, look, I think, all of this time, I was quite different, I suppose, as a pelvic health physio, because I wasn't really seeing a lot of incontinence patients. I was really, all of my pelvic health patients were really pain patients. So, but I hadn't really considered the athletic group. I hadn't considered these fit and active people with having pelvic floor dysfunction. Which in retrospect is crazy, but at the time, my brain wasn't thinking that way. So we had a big chat, and she agreed that I would assess her pelvic floor. We did that, and hey ho, we reproduced all of her symptoms, all of her pain, and she had how I would describe it as a non-relaxing pelvic floor, tender on palpation, reproducing her symptoms locally and referring them. She was quite sensitive in that area. There was an sensitization of the nerve and the muscle, I think. And what we did was we desensitized it. We mobilized the tissue. We did a big explanation of how muscles don't let go, and how muscles that are definitely not relaxing can have metabolites in them and cause pain in themselves, even though there's no damage in the muscle. Because she was, of course, coming from a athletic point of view, she was looking for the injury. She was looking for what was the cause? How can I repair this injury and get better? So she was really my very first person that I saw. And then what happened was I started looking. I briefly met a guy called Damien Griffith, who's an orthopedic surgeon from Warwickshire, who wrote the international consensus paper on femoral acetabular impingement syndrome, or if you like, labral tears and anterior hip pain. And him and I had a conversation when I was teaching with Ruth Jones in Birmingham one day about, if you like, people that had total hip replacements but still had hip pain. And Damien said to me that he had an idea that he felt that it was a muscle that was not relaxing and causing that, and it was a musculoskeletal pelvic floor cause of this pain. And actually that really resonated with me because and he felt it was a specific muscle, obturator internus. And I think these kind of events happening made me suddenly start to think much more broadly and not really limit myself when it came to thinking about, well, you know what, of course, athletes have pelvic floors. And so, sometimes we're so close to what we do. Sometimes it's right in front of us that we need someone else to light the taper so that our brains fire up and we maybe get more of an idea that we should be looking at. So that was really how it started. And then it's just saw more and more people. And I think, again, that the sports world is quite small. And so they all talk to each other. And I think what happened was, if you've got a pelvic floor issue or a ductor issue or something that's happening in your pelvis and it's not settling, go see Bill, because he does something different and he might be able to help you. And so that was really how my interest in sports and pelvic and athletes' pelvic health came about.
Yeah, and you've been also supporting the ballet, the Royal, how do you call it?
It's the Scottish Ballet in Glasgow, and I've worked with them for a long time. And I worked with, basically, we were with them for quite a significant length of time. And then about 3 or 4 years ago, I kind of took a step back and became the consultant physiotherapist there. And then with COVID, I haven't really been there very much, but we have a really good team there. The big thing for me there was that I see quite a few dancers with hip problems that are coming from the pelvic floor, and I tend to. So what I've done in the last years is I've been doing a lot more contemporary kind of dance work, and it's quite interesting to see the difference because of the type of postures that ballet dancers assume and the type of postures that modern dancers assume, and they do have different injuries, still pelvic floor type injuries, but they're. I had a dancer recently who came in with chronic hamstring insertion pain, and she is a Moulin Rouge type dancer, so can dancer and a commercial performer, and she basically had suffered this for quite some time. And anyway, to cut another long story short, we did all of the normal assessment for hamstring, and we couldn't really reproduce the pain. And we did hamstring rehab, graduated loading, eccentric control, kind of proprioceptive work, and we did all of the things that we would normally do, and it didn't get better. And I realized, interestingly, in pelvic health, sometimes because of its nature, your bias makes you slightly blinkered. And this dancer I had known since she was about 10, and I had followed her all the way through her junior dance training, through her university dance training, and I'd seen her commercially when she was a commercial dancer on and off for many years, and she's now 30. And I realized that I felt slightly uncomfortable suggesting that she had a pelvic floor issue, and also with the idea that it might be me that would have to do something about it. Now, I'm really lucky because in the clinic, I have 3 other pelvic health physios that work alongside me, and we work really closely. So I was able to go to Elaine, my other physiotherapist, and say, look, could you please have a look at this lady's hip? Because I'm absolutely sure it's coming from her pelvic floor. And she saw her once, assessed that was the case, treated her, and the pain went away. And you think, wow. So it's the dance world is the same. The thing that's good about dancers is if you say to them, could you switch off your pubococcygeus, and it's right here,
they will know.
They just do it. they just do it. Yes. They're a great group to work with, and you learn a lot from them. I always say to dancers dancers often say to me, how do you know so much about dance and physiotherapy? And I'll say, from dancers. Dancers tell me everything. I learned almost everything I need to know about dance physio by listening to what dancers have to say. So the dance world is very exciting. It's a good place to work, and I think we, as pelvic health / MSK physios, we can help a lot of dancers, I believe. I think we can definitely do that.
How do you find the level of awareness regarding pelvic health among dancers in general, or ballet dancers eventually?
So it's a good question. I mean, I think I would say, first of all, that the level of awareness generally is pretty poor, like across the public domain. I think pelvic health is really important in men, women, and all genders. It's not isolated to the female gender. It's right across the board, and I think it's right across the whole of society. I think that there's a lot of myth out there about pelvic floor. I mean, I think the typical one is that women think it's normal to leak after they've had a baby, and I would often say, well, it often happens, but that doesn't mean to say that it's normal. I find that word normal slightly worrying, because it means that you're maybe making the person feel they're abnormal, and then that somehow they've failed a little bit, when in fact it's nothing to do with that. It's nothing to do with not succeeding. It's to do with the trauma that your body's been through, and you've had a change, and that change has caused the tissue not to work as efficiently. So you need some help as to how to make that happen again. I think the other thing about men is men don't really have a clue that they have a pelvic floor. And I see a lot of men with erectile dysfunction, and men think erections are a gift from the gods, and they're bestowed upon them from on high. And they have no connection between how that might work, and that's not true for every man, but generally that is the case. And when something goes wrong with the pelvic floor, they're often bemused, perplexed, anxious, upset, quite focused to get something to help it, and it's all of that is understandable, I think. But I think. We have a very cool woman in Scotland called Elaine Miller, and Elaine is a physiotherapist and a stand-up comedian, and I think that she has done a lot to advocate for women's health and for men's health and pelvic health in general, and she continues to do so through a combination of public health education, through her comedy, with a really important message there behind it, and she does that globally. She's been to Australia. She does her stand up in all over the UK, and I think there's definitely a shift. There's probably a couple of other. I think there's a couple of other female kind of comedians that talk about menopause and talk about women's issues. There's few that talk about men's issues, and it's one of those things that guys they don't want. They traditionally don't want to go to the doctor. They certainly don't want to talk to their friends about not being able to get erections or not being as functional sexually as they maybe would like to be, and it's a kind of an area that they just don't want to talk about. And especially, I think in Scotland, Scottish men are quite kind of reserved about that. And so I think one of the things I always get, I don't want to get blasé about this and how patients talk to me, but the one thing that patients say to me every week is, after I've listened to them, is they say to me often, this is the first time that I've really felt heard. I really think this is the first time that someone has heard what my issue is, because I think as physios, we're very keen to take the information, and we're very keen to impart our own sense of what that patient might need. But in actual fact, the person that knows what they need most is the person in front of you. And I'm always keen to say, what is it that you need from me? Not what can I give you or what can I do for you, but what is it that you need from me that will allow you to get back to your life, that will allow you to function the way you want to function, that will make you happier, that will give you hope, that will make you feel less misery, that will make you get back to living your life. And I think for me, that's the biggest drive, I think, for me in pelvic health. I think that the kind of buzz that you get out of treating this group of patients is huge, because and not that any other patient in their reality is any less valuable, but this has such a big effect on people's lives and on their being and on their relationships and on everything that they do. So it's so huge. And actually, sometimes the input that we give is quite small. We don't often always need to do big things to get it. Small things sometimes give you a big change. I think sometimes with complex pain patients, where there's a kind of a discussion in physiotherapy that you shouldn't let your patients become dependent on you, or you shouldn't let you, and that's absolutely true. I think that's true. Except I think I maybe said this on the course because it's something I actually believe. I sometimes invite my chronic complex pain patients to remove the yoke of their pelvic pain, put it in the corner of the clinic and leave it there, and don't feel they have to take it with them because they've been carrying it for such a long time, that I want to give them the support. And maybe, and maybe this is controversial to say, but maybe a little bit of dependence for a short time isn't such a bad thing, to help them see that they can turn this journey around and take back their self-worth and take back their own direction and feel that they can get back to the life, all of the life that they can manage, really. So yeah.
It's offering support, honestly. Yeah. It's actually offering support.
Yeah, I think it's the support and saying it's okay, that you everything you're feeling. I often have a lot of my guys say to me, oh yeah, they said I'm just anxious, and they said I'm just too nervous, and they said I'm too fixated on the fact that my erections don't work, and they said I'm depressed. And I'll say, well, I think that's reasonable considering all of your symptoms. And I don't think that I don't think it's unreasonable to be feeling those things. And I think that's normal. So let's see if we can't do something to maybe help you not feel that way. Let's see what we can do from a physiotherapy point of view to help some of those feelings you have and to get you back to your life, really. I think that's it.
Exactly. So going a little bit back on what you said, do you feel that it's still difficult for physiotherapists, and not only, to ask their patients about the status of the pelvic health?
So I think it could be. So I think the simple answer is yes for some physiotherapists. I think other physios won't have a problem with it. And I think if it's your personality to be comfortable and relaxed about your own sexuality, your own situation, and your own life, and you have no kind of concerns or blocks to talking about that, then I think then it's easy. But I think sometimes as physios, we worry a little bit if we ask questions about that we might get answers that we're not equipped to deal with. And I think that's a reasonable thing to say, because we always have to be aware of working within our remit. We're not sex therapists, we're not sexual health specialists as such. So I think yes, it is. I think we can make it easier by using kind of pro forma questionnaires to assess the kind of qualitative situation that patients find themselves in. And those questionnaires can often ask questions about sexual function that allow us a segue, if you like, into asking more questions. So if, for example, if there's a question on the questionnaire that asks about erectile dysfunction and the patient has ticked yes for that, it then makes it much easier for you to say, so can you tell me more about your erectile dysfunction? And can you tell me more? I mean, the thing for women, I think often women have quite a hard time speaking about dyspareunia or painful sexual intercourse, because they feel sometimes ashamed. They feel sometimes that their body is failing them. They feel that it might be the very first time that they've even mentioned it to anyone. And the other thing that happens is if they've mentioned it to maybe a medical practitioner who's also not comfortable talking about this, they might have been left with more shame. and they might think it's something they can't bring up. So I think on the course as well, when I teach my pelvic health courses, I always say to physios, be really aware of your sensitivity to those questions, and try, and if you ask them, understand that there should be no shame attached to them. There should be never any judgment. There should be never make the patient feel worse about telling you something that it's taking them an awful lot of courage to divulge, for sure. And I think that I say to physios, if you're uncomfortable about it, then maybe do it on the questionnaire. You have that information. You can ask quite kind of practical, pragmatic questions about it, and still feel that you're within your scope of practice, I think. So, yeah.
Yeah, I do agree. And another thing that you've mentioned, and that made me realize about my bias, yeah, exactly, is that I've been looking a lot after research on pelvic health dysfunctions, or pelvic floor dysfunctions, if we want to put it more specifically, amongst female athletes. But I don't really remember of looking after research on male athletes. And you pinpointed that for us during your course, that there's barely, if any, research on pelvic health among male athletes. Would you also like to elaborate about that a bit?
Yeah, I think that's certainly true. And I think I'll tell you a slightly funny story about that. So I was teaching in Norway not that long ago, and there's a significant, Norway has some fantastic physiotherapy researchers and specialists, Caribou, Nygaard. There's a whole bunch of very good well-cited people in Norway who are bringing out some really interesting work, looking at, so, dancers, trampolinists, varsity athletes, but all of them were female. And during my talk, and sometimes, it is true, even though people are teaching courses, we don't know everything. And I had said, I had done the same thing as you. I'd spent a long time trying to find articles on pelvic floor dysfunction in men. And I said I couldn't find any. And there was a physiotherapy researcher in the course who put her hand up and said, I did one.
Yay.
Yay. And her paper was in 2020. I don't really know how I missed it, really. And she looked at powerlifters, and they looked at the effect of whether these guys had pelvic floor weakness or dysfunction. So it is out there, but it's definitely, I think culturally, it's a reflection of the fact that we didn't really consider the male pelvic floor. We did. I mean, most of the research in male pelvic floor is around surrounding prostate cancer, post prostatectomy, rehab, or benign hyperplastic prostate growth. So it all really surrounds that, and not much really around and incontinence and erectile dysfunction in that field, but not really looking at young guys with pelvic floor dysfunction, which of course is probably, I would think, because 50% of my caseload is pelvic floor, probably 75% of that caseload are young guys under the age of 30 with pelvic floor dysfunction. So it does affect that group, and those groups tend to be the more athletic, more active. Not always, but they tend to be the more athletic, more active group. And if there are professional athletes or even semi-pro athletes, they're usually most sports you peak in your earlier years rather than your later years. So these guys tend to be in that younger age group. So yeah, there's an absolute dearth of knowledge in that area. And I think the people at the Norwegian School of Sports Science in Oslo are working on that. They're definitely developing more research in that area, which is really, really needed.
It's necessary, yeah.
Absolutely.
Okay, so maybe to finalize, would you like to let us know about your very own definition of what pelvic health is?
Wow.
Yes.
Okay. So what is
well, for you to, just while you prepare, I keep asking myself what pelvic health is, and I have a bunch of definitions, and sometimes I really like some of them. Other times I hate the same that I loved previously. So just feel free to put it out.
My one answer is it depends which day it is.
Yeah.
And it depends which patient. So I think that for me, the pelvic floor and the pelvic area is not disconnected from the rest of the body, and it is connected to the whole of us. It's part of our whole being. I think the mind-body connection there with our sexuality, with our gender, with women having babies, with men procreating, I think with all of that, there's a huge cultural, sexual, psychological connection. So it's got to encompass all of those aspects. It can never just be. I think it's certainly moved away from the idea of someone lying on a bed clenching their pelvic floor muscles 10 times times 4 as many times as they can during the day. That's what it isn't for me. It's definitely not that. And I suppose I find that easier to tell you what it isn't rather than what it is. And it's this very complex, intriguing area that produces a multitude of different issues locally and throughout the body. And is from a physiotherapy point of view, for me, it's probably one of the reasons it's such an amazing area to work, because it's such a challenge. And I consider myself supremely lucky at this stage in my career to still be absolutely amazed and intrigued every day about trying to help pelvic floor patients. So I think it's this non-pelvic centric idea that the pelvic floor is connected to the pelvis, the spine, breathing, locomotion, and movement in general, and that we have to look at the whole person, and we have to listen to the patient's narrative. We have to let those patients be heard, so that they can have the best pelvic health that they can. And I think it's this idea of it. And I think pelvic health, from being kind of like a little bud of tightly held kind of petals, is kind of blooming, and it's continuing to bloom, because there's some fantastic researchers all over the world that I read another article, I read a systemic review, and suddenly my definition of pelvic health is changed again. I meet my mentor. I talk to my mentor, Kate Walsh, who's an astounding pelvic health physiotherapist and has to have a mention. And I come away thinking, wow, I have another perspective on things. And for me, it's kind of what I do. It's who I am. So it's all of these things for me. It's not one thing over here. And I'm part of all of that. And I just feel really privileged and kind of proud to be part of that group. As I think I said at the beginning, I still feel a bit of an imposter. Someone else that deserves a mention is a community called Pelvic Roar, that was started by Myra and Elaine and I think maybe Miriam, I'm not sure. But anyway, it's an online community where I've never felt more kind of included from a physiotherapy point of view. With sometimes the way social media is, it's not such an inclusive space, and I find that Pelvic Roar is a place that you can go to and say things, post things, ask questions, and never be afraid that you might look a little silly, because I always say to people when I'm teaching, I said, if you have and I say to patients as well, I'll say, the only stupid question is the question you don't ask, because that's the question that you actually need to ask. Because if you're thinking that, then someone else is thinking it, and someone else has thought it before you. And if you say it, then I will learn from that. So pelvic health for me is this kind of, it's from right from the pelvic floor to this expansive world and vocational space that I live in. That means it just means so much to me, really, because I'm super keen and passionate about it. And I think if you had told me 30 odd years ago at the start of my career, we'd be having this conversation and I'd be saying to you, yes, I'm a pelvic health physician, I wouldn't have believed you. And so I like that. I like that about it. I like the fact that it was a surprise to me, and yet a very good surprise.
Well, and we all thank you very much for becoming such an incredible pelvic health and not only physiotherapist. And I just like to tell you that regarding that sense of imposter syndrome that you may feel, I think there's some goodness on that. I think that's probably it's mirroring how much you've been pushing your boundaries about your beliefs regarding pelvic health and physiotherapy in general. And well, I think that probably you should start looking at it from that angle as well, because there's for sure a lot of goodness on that. So thank you very much once again. This was such a wonderful sharing. I mean, there's so much to what you said, so much that could still be said, and I'm sure that we'll keep talking throughout our long lives.
Thank you very much. It's been lovely speaking to you, and it was a blessing to meet you in Liverpool. And I'm sure I'll be talking to you and getting some advice for you over the next few months.
Yes, likewise. So thank you very much, Bill. And see you soon.
See you soon.